There's so much that floats around between social media, news media, their own anecdotal experiences. And my general counseling with patients is some context in that, if you get flu, the benefits of it greatly outweigh any risk that may be associated with it. I mean, if you're at risk, it's going to significantly reduce your rates of complications from flu, hospitalizations.
Staff education and re-education, we do it all the time. And as stuff changes, administration, new technology, some of the new vaccines don't have needles to reconstitute anymore. Some are shaken, some are not. Some only have 30 minutes that you can give the vaccine.
Welcome to Medication Talk, the official podcast of TRC Healthcare, home of Pharmacist Letter, Prescriber Insights, RX Advanced, and the most trusted clinical resources. On today's episode, listen in as our panelists review the latest COVID-19, influenza, and RSV vaccine recommendations and answer some common questions about giving vaccines. Our guest today is Dr. Kelly Goode from the Virginia Commonwealth University School of Pharmacy and former president of the American Pharmacists Association. You'll also hear practical advice from TRC Editorial Advisory Board member Dr. Stephen Carek from the USC School of Medicine, Greenville. This podcast is an excerpt from one of TRC's monthly live CE webinars. Each month, experts and frontline providers discuss and debate challenges in practice, evidence-based practice recommendations, and other topics relevant to our subscribers. The full webinar originally aired on October 15, 2024.
And now, the CE information.
This podcast offers continuing education credit for pharmacists, pharmacy technicians, physicians, and nurses. Please log into your Pharmacist Letter, Pharmacy Technician's Letter, or Prescriber Insights account, and look for the title of this podcast in the list of available CE courses. For the purposes of disclosure, Dr. Goode reports a relevant financial relationship by receiving honoraria from Pfizer and Valneva. The other speakers you'll hear have nothing to disclose. All relevant financial relationships have been mitigated. Now, let's join TRC editor, Dr. Sarah Clockers, and start our discussion.
Kelly, to kick us off, can you briefly review the main changes to the flu vaccine this season?
Yes, Sarah. This year, the World Health Organization and the Food and Drug Administration recommended a change. You may recognize it. We used to have a quadrivalent influenza vaccine to a trivalent influenza vaccine, and that's because there's been surveillance in looking for the influenza B Yamagata lineage and not found that since March of 2020. And so don't want to have more antigens than we need. So they removed that B Yamagata. This year, there'll be the 2As and H1N1 and H3N2. And then the influenza B is going to be the Victoria lineage. So they were able to make that change for all of our influenza vaccines this year. So they're trivalent and not quadrivalent.
Excellent. Thank you. Stephen, I was wondering if you can share what conversations you have with patients about which flu vaccine to get, and how do you answer the question, which flu vaccine is best when patients are in the office?
In my own practice, the best flu vaccine is the one the patient's going to take. But yes, there are guidelines, and at least in my clinical setting, we typically have two available to us. For our clinic, we have the high-dose Fluzone we're going to recommend for adults over 65. And then we actually use Flublok in our clinic too. And some of these, if you're in a big healthcare system, they may only give you a small handful, 1, 2, maybe sometimes 3 vaccines available for you. But to be honest with you, in my own clinical practice, I don't know if the data outlines any significant difference. I mean, the best one is going to be the one they're going to take, or the high dose. They have some added benefits, especially for elderly patients, in preventing intensity of symptoms, reducing hospitalizations, but ultimately any flu vaccine is going to have significant effects over being non-vaccinated, especially for our at-risk and elderly populations.
We have had a couple of audience questions where they've had several patients over 65 ask for the regular dose flu vaccine instead of the high dose. How would that conversation go with the patient in your practice?
Yeah, I'll talk with them about it and say that, guidelines are going to recommend using a higher dose, understanding what their concerns are. Is it sort of that they may get the quote unquote flu from the flu shot or have some sort of adverse reaction to it? try to understand what their fears are. But ultimately, if that's the one they're going to take, if they say, I don't want to take the higher dose and I'm going to take a regular dose flu shot, I'll give it to them. And again, it's going to provide benefit. It may not be the optimal benefit or the highest amount of benefit, but at least it's going to significantly reduce symptom duration potentially, and then definitely things like complications and hospitalizations from the flu.
Which leads us very nicely to efficacy. We have a lot of questions coming in about how do they determine efficacy? How effective are the flu vaccines? I've even seen some headlines about how they're not as effective this year based on data from the Southern Hemisphere. So how do you explain the benefits to your patients, despite some of these headlines or some of the vaccine hesitancy out there?
Oh yeah, there's so much that floats around between social media, news media, their own anecdotal experiences. And my general counseling with patients, I'd probably give you a 50% chance it's going to probably be effective. And just know there's a lot of strains circulating, and this is only covering kind of the three main ones we want. But what I can definitely provide for you is some context in that, if you get flu, the benefits of it greatly outweigh any risk that may be associated with it. I mean, if you're at risk, it's going to significantly reduce your rates of complications from flu, hospitalizations, and then try to clarify some misperceptions and misconceptions of things like, if I get the flu vaccine, I'm not going to get the flu. Well, that's not necessarily the case. The goal is that you could still get the flu, but your symptoms are going to be less. Your symptoms are going to be shorter, potentially be less contagious. And then for our higher risk patients, we talked about the complications and hospitalizations. I mean, those can dramatically go down with just being vaccinated.
Another question we've gotten, Kelly, is should a patient with multiple sclerosis or rheumatoid arthritis receive a high dose or adjuvanted flu vaccine? And if they do, will it be covered by their insurance? So just to kind of expand that question a little further is, should patients on immunosuppressants get high dose or adjuvanted flu vaccine?
Yeah, Sarah, and so some of the confusion might be that in June of 2024, the Advisory Committee on Immunization Practices recommended that someone with a solid organ transplant that's 18 years or over and receiving an immunosuppressive medication regimen could receive a high dose or adjuvanted influenza vaccine, but it's not a preferential recommendation similar to the one that Dr. Carek was talking about, where it is preferential for somebody who's 65 and over to get an adjuvanted, the flu block, or get a high dose influenza vaccine. They could get it. And based on it being a recommendation, the insurance should pay for it, but we do find that sometimes it takes about a year for insurances to implement ACIP recommendations. So they may not be willing to pay this year, but that's the recommendation that they could have it. So when we look at someone with multiple sclerosis or rheumatoid arthritis, they would just receive an age-appropriate vaccine, not a high dose or adjuvant, unless they're 65 years or over.
I just have a few more quick questions about the flu vaccine before we move on. How long does the flu vaccine last, Kelly? We have an audience question about this. Should a patient get a flu booster because they got one at the beginning of August?
Yeah, this question, it comes up every single year is should we have a second flu vaccine? And there are a few patients that could get a flu vaccine in August. One of the things when we really had just a standard flu vaccine, we didn't get flu vaccines as early as we get them now. So the technology is much better, so we can have flu vaccines much earlier. But really, patients shouldn't be vaccinated until September. So they shouldn't have a vaccine in August unless they're pregnant in their third trimester, if there's somebody who may never come back during the influenza season, or a child who may need a second dose. But we do know that the influenza vaccine is going to provide protection for at least the influenza season. It does, however, can wane over time, and we know that that's going to vary by the strain, by the recipient age. But generally, we're going to see a persistent of about 5 to 6 months, which should carry us through the flu season. And there's not really an indication for any patient to get a booster dose of their influenza vaccine, and even if they were vaccinated in August.
Mm-hmm. Which leads nicely to the next question is, when should we stop giving flu vaccines?
Yeah, we should stop giving flu vaccines when we run out of flu vaccines or they're expired. We should continue through even the spring. So flu vaccine season in the Northern Hemisphere is really mostly December through March. However, we see the high rates January, February. If you go to CDC and look at Flu Weekly, you can kind of track influenza in your communities. We always do that because we want to see when it shows up on the news, that's when patients are going to come in and say, oh, I need the flu vaccine now because it's circulating. But you can take that flu vaccine in through the spring. We vaccinate in our practice through March. And if we have somebody that's really high risk, we might even do in April, depending upon what we're seeing. But really making sure, your vaccine is unexpired and vaccinating as long as you have flu vaccine in your practice.
Great. Thank you. We're going to switch gears to COVID-19 vaccines now. Kelly, can you review the available COVID-19 vaccine options this season? And specifically, we've had a lot of questions about differences between the mRNA vaccines and the protein-based Novavax COVID vaccine.
Yeah, so we have 3 vaccines that we've had for the last couple seasons. So we have 2 mRNA vaccines, the Moderna, the Pfizer BioNTech, and then the Novavax. So just remembering that the mRNA vaccines are that lipid nanoparticle formulated and the nucleoside modified mRNA. So what it does is it encodes sort of that spike glycoprotein of SARS-CoV-2, which is the COVID-19 disease. That's the virus that causes COVID. And so the formulation for this year, for the 24-25, is going to target specifically of the mRNA vaccines, the Omicron variant of the KP2 sublineage of the spike protein, which is a part of the JN1 lineage, is kind of what we're seeing. If you look at the variant tracking for COVID, that's kind of what we're seeing. And that's what the VRBPAC committee sort of recommended for COVID vaccines for the fall and sort of the end of May or June of this year. And then the Novavax is more sort of the protein-based vaccine that we're really kind of used, similar to our other vaccines, and it's going to target the JN1 variant. And so the COVID-19 vaccine, Novavax, is adjuvanted, and that's sort of to help the immunogenicity of that. And it has a spike protein and a matrix M adjuvant to sort of bring that and make it more immunogenic against COVID-19. So you're looking at approval for Moderna and Pfizer for the spike vaccine, Comirnaty, and then the Novavax, and then the EUA for your children up to 12. The other ones are 12 years and over. Novavax 12 years and over, but you have an EUA still for children for the 2 vaccines that are under 12.
Similar to the flu vaccine, it's recommended that all patients aged 6 months and up get a 2024-2025 COVID-19 vaccine. And so with that being, we have this new COVID vaccine this year. How many doses do people need?
Yeah, so it is a little complicated. So everybody should at least have one of the 24-25 vaccines. If they've never been vaccinated, ACIP is actually going to discuss the dosing for immunocompromised patients next week at the October meeting and sort of really put it into recommendations for clinical guidance, as well as potentially another dose for people who are 65 years and over like they did last year. So my recommendation is really these are great charts from Pharmacist Letter, and the CDC also has a great chart to sort of help you. And we always go back and look it up just to make sure as we're looking at people, especially children coming in, whether or not how many doses they might need depending upon the product we're using.
So, Stephen, I would like you to chime in here since you helped us with the efficacy of flu vaccines. How effective are COVID vaccines, and how do you convey the benefits of these vaccines to your patients?
Yes, this presents some similar challenges that we have with the flu vaccines. I think the headline for the COVID vaccine is just the significant reduction in hospitalizations and mortality associated with COVID. I mean, that's really where this was a game changer, especially when we're going through these peaks through the pandemic these past few years. As we're sort of like getting more and more data on the efficacy of vaccines, I think we're seeing trends that it does a lot of the same things the flu vaccine may. It may decrease infection transmittability, decreasing intensity of symptoms, but what we're trying to do is just still with COVID, really reduce those risks for really severe complications that COVID is really notorious for, particularly in our elderly patients, our high-risk patients, and then trying to encourage all people to get vaccinated. We'll see over the years go along if we're going to continue the pattern of annual vaccinations, but continue to emphasize not just the benefit for them, but for the people that they're around, their loved ones, particularly those that are high risk for complications related to COVID.
Mm-hmm. Thank you. one of the areas of hesitancy with the COVID-19 vaccines are side effects. And so we have had a lot of questions come in about COVID-19 vaccine side effects. So there's actually a specific question about heart attacks and myocarditis concerns. And can you comment on this? How should we handle some of these COVID vaccine hesitancy? So, Kelly, I was wondering if you could comment a little bit on side effects with these vaccines.
Yeah, so if you look at the safety surveillance, CDC's we've got 3+ good years of safety data on COVID-19 vaccines. And really, it's not panned out to have, some of the concerns of, some of the early myths of COVID vaccine. I mean, there are some side effects when we look at, giving any vaccine. The mRNA can be especially sort of reactogenicity when you look at potentially pain, swelling, redness at the site, sometimes fever, fatigue, headache, chills, body aches. I have PTSD under all my COVID vaccines, but I still go back because I think it's less than COVID to have some side effects. But we do know that, most people may have some of the side effects, but there are a lot of people who don't have those side effects. So it's going to depend upon kind of the vaccine product and sort of the age group of the patient. But mostly we do know that almost 55 to 91% of patients do develop some sort of symptom after a COVID vaccine. But most of them are mild and moderate and occur within the first 3 days and are resolved. Mostly, a lot of times, our patients we see resolved within 24 hours. Children have, not as many side effects, really moderately, and they're going to resolve in the same amount of time when we look at an mRNA vaccine. For the Novavax, it's going to be similar to what we see with other inactivated vaccines. We have tenderness at the injection site, local reaction, fatigue, headache, muscle pain are some of the symptoms that are reported, and it also resolves within 1 to 3 days. And if you think about some of the adverse effects and talking with patients, it's 1 to 3 days is much less than potentially what you might have with getting the COVID-19 virus itself or infection, and potentially even having it go into long COVID and having a much more severe case. So I think that it's definitely worth having those conversations with patients and making sure that you tell them that there's a potential, right? So we don't want to make them think that it's not going to happen. We always are open and honest with our patients that they could feel kind of bad, but this is much better than COVID. And when we look at myocarditis, that's really in our young men, and that's not panning out as much as we had before. So you do just have to think about in those young adolescent men, making sure you kind of have those conversations around the COVID that they could expect to potentially. We have seen that with COVID-19 vaccine.
Thank you for that. And we actually have an audience question. We have a lot of patients returning to the pharmacy with side effects of COVID vaccines. And what should we be recommending for symptom relief?
So what we do is really recommend what they would normally take for pain or fever. You got to make sure you understand history. So you don't want to be recommending an NSAID or, Tylenol if they shouldn't be taking it. So that's how we approach it. And they can sort of take that around the clock, especially within that first 24 hours to sort of get through the body aches or how they're feeling.
Excellent. Well, thank you. And then one last COVID question. For patients who have a recent COVID infection, should they still get the vaccine? Stephen, what are you telling your patients to do?
I believe that the CDC recommends 3 months. That's kind of just my general guidance. And when we're asking them if a patient is due for a COVID vaccine, just ask them if they've had it within the past 3 months. I don't know of any contraindication to getting it beforehand. I guess it's a matter of efficacy, which we don't really know. And then I guess as we talked to, getting the vaccine and then having some sort of side effect related to it. There could probably be some patients that may benefit. I mean, if they're frequently around patients who may be high risk, or maybe there's a surge going through their community, or maybe a time and a place to do shorter than that 3-month interview. But my own practice, we're pretty consistent about 3 months or so.
Great. Thank you. I'm going to go ahead and move us along to RSV vaccines. So this season, we have 3 RSV vaccine options. Kelly, can you review those options for older adults this season?
Yeah, so last year, you may remember we had two options. So we had our Abrisva, which is the bivalent vaccine, and then the Rexv, which is the adjuvanted. And then this year we have Mresvia, which is an mRNA vaccine. And so they're dosed the same recommendations. So they're considered equivalent. So it doesn't matter which vaccine that you use for patients. They do have a little bit of a different. This is a time when we think about FDA approval versus what ACIP is recommending. So it is a little bit different in how they've been approved and the recommendations that ACIP has decided for the three vaccines. Remember, ACIP is going to recommend based on cost effectiveness and the ability to get it to the population of target and acceptability, as well as efficacy and safety. But they're all administered IM 0.5 mLs. So any product is fine in that patient population, and the recommendation for 60 and over for the people that are high risk or those 75 years and over for the one vaccine.
Thank you. And then, Stephen, if a patient's already had an RSV vaccine, should they be getting another one?
That's a good question. Eventually, maybe. Yes, I think that we're still trying to figure that out. I think guesses maybe every 2 years. Kelly, I don't know if you have any other more insight on sort of recommendations moving forward, but my kind of understanding is possibly every 2 years, but we'll probably know more in about a year or two.
Yeah, I think that some of the emerging data might put that at about 3 years, but you're right. It's not going to be 1 year because the data didn't show a better antibody response with another dose at 1 year. So maybe 2 years, but it might even go as far as 3 years or even further, just depending upon they're beginning to measure all of that to see what intervals is going to work the best.
Thank you. And we also had another question about what is the RSV vaccine really preventing? So, Stephen, how effective are RSV vaccines, and how do you explain this to patients?
So RSV, a common virus that we see a lot, but I think it's also kind of a significant cause for hospitalizations, particularly for pneumonia in our older patients. I mean, viruses can be a significant cause for pneumonia, bronchitis in older adults and those that are at risk for lower respiratory tract infections. And so having this available is really significantly helpful in that. I mean, we're trying to vaccinate against some of our main causes for pneumonia, but having a vaccine for this, and the data shows probably 75-ish, 80% effective in reducing hospitalizations associated with RSV and emergency department visits. So definitely has some clinically meaningful data to support its efficacy in helping manage one of the common reasons or common viral reasons for lower respiratory tract infections in our older adults.
Thank you. And then, Kelly, question for someone who has not been vaccinated against RSV yet, what is the right time to vaccinate?
Yes, you really want to vaccinate before RSV season, right? So right now they just get one dose. If they haven't been vaccinated, they're going to have the most benefit if it's late summer, early fall, just before that RSV season. So in most of the continental US, that's going to be about August to October. However, recommendations is sort of under the shared clinical decision making. If someone deems that are going to have RSV, as you can track RSV just like you can track flu. If it looks like we're having a surge and someone's unvaccinated at a later time, then the clinician can decide, or provider can decide that, yes, we think we should go ahead and vaccinate them based on surveillance and what's happening in the community.
Thank you. And we do have several questions coming in about risks with RSV vaccines, particularly AFib risk. So could you comment on that, Kelly?
Yeah, so in clinical trials, there were some patients that had AFib, and so they are doing post-marketing surveillance on AFib. The data that was reviewed this year from ACIP, looking forward to the next year after the 23-24 season, AFib didn't emerge as a statistical signal. However, there were two other statistical signals that did emerge that they're going to monitor, and that's the risk of GBS with the Arexvy and Abrisvo. However, doesn't seem like that was more than just a signal. And so they're continuing to monitor that as well. And that was in patients really 65 years and over. And then the ITP was also a statistical signal that kind of emerged, and they're going back and looking through vaccine safety data link to kind of look at the charts on those patients this fall to kind of see, was that really a correlation or causal to vaccines? That remember that CDC is monitoring through vaccine safety data link. They're monitoring it through VAERS reports, which is a patient can submit to VAERS. So it's not totally, they have to go in and really dig into those systems. Have your patients use the app to submit their information when they take these vaccines, because they're really trying to track and monitor, and that would be helpful if you have your patients begin to do this like we did early on with COVID.
Excellent. And then just let's briefly touch on when we should give RSV vaccines during pregnancy. Kelly, would you mind tackling that one as well?
This one I'm very passionate about. I think that we really got to be careful because there were a lot of errors last year with this vaccine and pregnant women getting the wrong vaccine and even infants getting the adult vaccine. So we want to make sure that we have the right vaccine. So it's the Brisvo vaccine, and it's recommended for patients 32 weeks through 36 weeks gestation. It's really September through January. So now through January for that pregnancy only. We should not give it. It's not like Tdap where we would give a RSV vaccine every pregnancy. We would just give it during one pregnancy. So if I'm pregnant this year, then, and I have 2 more children coming through at this point, I would not get an RSV vaccine to protect that infant. That infant should get nirsevimab for protection once they're born. So it's only one time for that pregnant woman during one pregnancy, but making sure that we have the right product because we don't want to have those errors for patients.
Thank you. We've had several questions come in about the CDC recommendations for RSV vaccines in older adults, and just wanted to review this. Recommended for all patients aged 75 and older, and then for those 60 to 74 with risk factors. So hopefully that'll answer some of those questions coming in.
And Sarah, I just want to
Yes.
add to that is that you don't have to have proof that patients meet one of the
Good point.
criteria from 60 to 74. If they say they have heart or lung disease, then it's okay to vaccinate them. If you're in a pharmacy or administering, you don't have to have a note from the physician saying that, yes, they have COPD. The patient attestation is fine.
Great point. Helpful for our pharmacists listening. Thank you. And since it's a busy time everywhere and patients often need more than one vaccine at a time, I see all of the questions coming through about getting multiple vaccines. And so, Stephen, we've had a few folks ask, what is the max number of vaccines that can be given at one visit? Some folks are saying they can give 4 or 5, but they're asking if that's really something they should be doing. So can you comment on what happens at your practice?
Yeah, I think that I've not seen ever specific guidelines on like what's the maximum number of vaccines that you can give. And I mean, it's pretty common, especially in kids, since for our well-child chicks, for kids to get 4 or 5 vaccines in one visit. So I don't see any reason why we couldn't necessarily translate that over into our adult populations now. Now, an adult is very different than a kid, based on their immune history or medications that they're on, comorbidities. We may want to be thoughtful about how many we give to make sure we sort of have that sweet spot of immunogenicity and make sure they get the response we desire. I mean, I think the most that I've done in clinical practice for adults is probably 3 within one visit. But whether it's a combination of flu, COVID, RSV, pneumonia, tetanus, any of the things that an adult would be available for. But some of it also may depend on your clinic protocols, your pharmacy protocols, nurse comfort, patient comfort. So there's definitely a shared decision-making component that goes into it as well. But I'm aware of any sort of maximum number that we can't exceed.
Kelly, do you have any other comments?
I agree, but we've given a lot more than 3. So you can give, you're looking at deltoid muscle, so that each vaccine should be separated by 1 inch. So it depends upon the size of the deltoid muscle, but we can give 3 in each deltoid muscle. And if you have 2 sub-Qs, you can give 2 more sub-Qs depending upon the vaccines you're given. So especially if we're trying to catch an adult up that's coming in to this country that's not vaccinated, we do a lot of vaccines. But that visit, it's also, I agree with Dr. Carek, it's based on patient tolerance and what they're willing to accept, and take as many as that we can get in them while they're there, and then bring them back to get the rest of them.
Excellent. And the shared decision making is huge. Thanks for bringing that up, Stephen. Question specifically about getting multiple adjuvanted vaccines at the same time. Kelly, how do you respond to that question when patients are hesitant?
Yeah, there's really not any recommendation that you shouldn't do that. So all vaccines can really be given together at the same time. You're using separate sites, separate syringes. There is some potential sort of a little bit of evidence and mostly theory that the two adjuvant might be more reactogenicity. And so you might have more reactions especially if you give two adjuvant at the same time. And even if you do the same arm, I would suggest one in each arm. That's what we typically will do. But there's not a recommendation to not do it, but you might consider, if you think there might be reactions, to maybe use a non-adjuvanted flu and then an adjuvanted vaccine if you're giving a flu with that visit. But there's no contraindication to doing the two together, nor is there any evidence that it decreases efficacy of the vaccines.
Thank you. We did have a comment about that as well, so thank you. There is a question too about, so if a patient decides to defer vaccination and only get, say, two, when should they come back to get the rest? Is there a minimum or a maximum time in between vaccines?
So for inactivated vaccines, they could come back tomorrow. They could come back later the afternoon. So there's no minimum interval between two inactivated vaccines. If they're live vaccines and they're not given on the same day, the same clinic visit, we would need to wait 4 weeks. And that's a minimum of 28 days between the two vaccines. And that's a theoretical again, because we think that perhaps that second vaccine, the first vaccine that's given is, remember, the live have to kind of replicate to begin to work to have some immunogenicity. And so that it might interfere with that second live vaccine being given. So there's no grace period in that 28 days. So you have to have the 28 days between those two live vaccines. If you have a live vaccine today, I can get it inactivated tomorrow, and vice versa. If I have an inactivated day, I can get a live tomorrow. There's no minimum interval between an inactivated and a live. It's just the two live vaccines.
Excellent. Thank you. And I wanted to wrap up with a little bit about safety. We have actually had an audience question, which makes me think that errors are occurring. But what are the risks if a pediatric patient is accidentally given 0.5 mLs of Moderna's COVID-19 vaccine instead of the 0.25 ml dose? And I think that just points to dose differences with COVID-19 vaccines. And Kelly, can you just share some practical tips that we can use in the clinic and the pharmacy to help us pay close attention and triple check those doses? You know, especially with this example, since Moderna's COVID-19 dose does vary by age. So just some practical tips to share with the listeners.
Yeah, this is what I'm very passionate about, making sure we don't have vaccine errors. It's really, so it starts from how you store vaccines, right? So not storing lookalike vaccines in the same area of the storage unit, making sure that you have pediatric and adult formulations that are separated, and making sure staff are educated. You have to continually educate your staff, right? Because the staff are going to change, and you have to make sure that they understand what's being there. So you want to do that. You want to prepare one vaccine for a patient at a time and labeled with a syringe that's there. We, in our clinic, do double verification. So once a vaccine's pulled and the order is compared, someone is actually so we now sign that it's been verified, and then who's administered the vaccine. The other thing that's really helpful is that if you're documenting on a piece of paper, or even documenting in an EHR in a pharmacy system for what vaccine that you're giving is doing that first and the lot number and the expiration, and then you're less likely to give an expired vaccine or give the wrong vaccine because now you're doing that. And then confirming the patient vaccine. Ask the patient, you're here today to get, this is your influenza vaccine. Make sure the patient should kind of know what they're getting. And it's another check, and making sure you can show the patient the syringe, but always triple checking those doses and making sure that you have, because errors are really a lot more vaccine errors than we think there are, but making sure that you're following these steps can really help in making sure you remove that expired stock. And then just staff education and re-education. We do it all the time to make sure everybody, and as stuff changes, administration, new technology, some of the new vaccines don't have needles to reconstitute anymore. Some are shaken, some are not. Some only have 30 minutes that you can, once you've reconstituted, you've got to give the vaccine. So if you don't want to waste it, you got to make sure that patient's going to get it, especially if it's a child getting something like a varicella. We have that happen sometimes, and they decide they don't want it. We've already mixed it.
We hope you enjoyed and gained practical insights from listening into this discussion. Now that you've listened, pharmacists, pharmacy technicians, physicians, and nurses can receive CE credit. Just log into your pharmacist letter, pharmacy technician's letter, or prescriber insights account and look for the title of this podcast in the list of available CE courses. On those websites, you'll also be able to access and print out additional materials on this topic, like charts and other quick reference tools. If you're not yet a pharmacist letter, pharmacy technician's letter, or prescriber insight subscriber, find out more about our product offerings at trchealthcare.com. Be sure to follow or subscribe, rate, and review this show in your favorite podcast app, or find the show on YouTube by searching for TRC Healthcare or clicking the link in the show notes. You can also reach out to provide feedback or make suggestions by emailing us at contactus@trchealthcare.com. Thanks for listening to Medication Talk.